It also protects against decreasing hypertension. You see the numbers there. I don't want to read it to you, but also it helps with cardiovascular disease. It also helps to decrease the development of diabetes. And one of the ones I wanted to point out there is that 36% reduced risk of sudden infant death syndrome. Benefits for the mom as well as for the infant. Why are moms stopping? Let's talk about that. So one of the reasons why moms stop is because their expectations of breastfeeding and the reality hits, and oftentimes moms stop. Also, we have noticed and have studied that there was a lot of lack of support from work policies, also lack of support from the paternal leave, also lack of support from the family, and also cultural norms. And this causes a lot of moms to stop breastfeeding very early. And so with this, we felt like education was needed. Okay. So statistical data.
Thank you all for being here. Can you hear me? Is my audio working? Okay, thanks. All right, it's 10:30. I'm gonna go ahead and get started. So thank you, everyone. Good morning. The Gilling School of Public Health offers an online degree with a focus on leadership and practice. The capstone course brings together public health practitioners with different sets of expertise to develop a practical solution to contemporary problems. My name is Askia Dunnan, and my colleagues here are Allison Smith and Abigail Warren. With guidance from our faculty advisors, we developed an interdisciplinary public health strategy to address county-specific population health outcomes by leveraging both nutritional and economic opportunities in Robeson County, North Carolina. By the end of this presentation, you should be familiar with the following concepts. First, system archetypes. Second, social determinants of health. And third, accountable care community. I also want to convey some methods that you might find useful in mapping out elements of various social ventures or other population health projects, which we found to be particularly helpful, yet not without a bit of a learning curve. Finally, I share some lessons I've learned about community engagement work. Am I muted? Can you hear me now? Oh, okay.
I can hear you.
Okay. All right, I'm going to go ahead and move forward. I think it's because maybe if I click off the window, does that change where the audio comes from?
So far I haven't noticed any changes.
Let me see. Okay. You can hear, okay. So different people are having different issues with the audio. Okay. All right. Okay. So I'll just go ahead and proceed. Yeah. Okay. And if anyone needs the slides afterwards, I can definitely provide them. Okay. All right. So finally, I want to share some lessons I've learned about community engagement work. All right. So before jumping into Robeson County, it's important to set the stage first. So what is a system archetype? So in layman's terms, systems archetypes are behavioral patterns of a system. They're usually represented by a causal loop diagram, where an arrow connects events that are interconnected. Positive sign represents an increase, while a negative sign represents a decrease. In the following thought experiment, I'm not sure if you can see my mouse. So if we were to imagine the U.S. healthcare system as a systems archetype, we could represent it by the fixes that fail archetype. So our input would be a preventable disease, and the fix would be increasing or providing the provision of healthcare services. In theory, this will temporize the original problem with some degree of unintended consequence. For example, prescription drugs and surgeries don't often completely fix the original ailment and often lead to complications. And so there's often a delay. Some of these unintended consequences might include, sorry, I'm having other pop-ups. Some of these other unintended consequences might be, for example, medical error. Medical errors leading to false diagnoses or increased morbidity. At the end of the day, what we know is that 1 in 3 patients will experience medical error when they encounter the healthcare system. We know that care is extremely cost prohibitive, and millions of Americans are uninsured or underinsured. And while health starts at home, many drivers of health, such as public policy, are determined not by individuals, but by the collective population. Some of these populations have contributed to the increased economic instability, such as the increasing costs or decreased access of care, the defunding of public safety and preventative services at the expense of clinical care, widening health inequities, and an overall morbidity and mortality increase in the general population. So one of those questions is why? So to make my point a little clearer, this county health rankings diagram shows how policies and health outcomes relate to one another. You see in the bottom, policies drive specific health factors, and those health factors impact our health outcomes. You may have seen many of these diagrams that illustrate relative proportion of these factors that contribute to health outcomes. So we know approximately 20% of your health outcome is contributed to by clinical care. The issue with that is that we spend about 90% of our health expenditures on medical services. And while only 20% of our care or our health outcome is contributed to clinical care, we ignore 80% of these other factors, such as our behavioral health, our social and economic factors, and our physical environment. So it's not surprising that when you put these two together, we see an increase in the mortality of the US population definitely relative to other countries. So with these factors in mind, we developed an innovative model of care that promotes health undergirded by policies which are economically stable. To do this, we first created a group problem statement. We brainstormed using rich pictures, and we finalized a root definition. And instead of me walking through each one of these methods, I'm just placing them here for your reference so that you know, if you're not familiar with some of these ideas, they're here for your reference. What I do want to do is show you this rich picture. So our rich picture emphasized the social determinants and how we collectively saw interconnections within these more focal issues. Using economic insecurity as our more focal issue, we researched local contextual data, including a lot of gray literature, interviews, news. We'll meet the Smith family and explain how they navigate life in Robeson County, then explain how our proposed policy and intervention would impact them. This is the Smith family. Karen Smith, pictured here, is a 45-year-old jewelry store owner. She lives in Robeson County, North Carolina, where the county median income is $33,700. North Carolina's median income is $52,800. Robeson County also has a 36% poverty rate as compared to North Carolina's 14%. And in Robeson County, 100% of children are SNAP eligible. She raises her son, Kyle, who just turned 15. His friend says he's a picky eater because he often complains about school lunches. He enjoys video games and is considering a college degree in environmental sciences. Kyle is SNAP eligible. SNAP benefits run out quickly every month since most of Kyle's meals are eaten at home, and he compensates by eating more at home because he doesn't eat at school. Karen says that food and finances are very personal. She hasn't reached out to any local resources because of the stigma. COVID-19 has made things particularly more challenging since she's now solely selling her merchandise online. She says that her son eats when he eats when he comes home, and she usually reserves food for him, and if there's anything left over by the end of the month, she's able to eat. The Smith household, like most Robeson County households, are food insecure. And so if Karen's sales fall, her house is in considerable trouble. So a question I have is, what percent of Robeson County, I have here residents, but what percent of Robeson County children are food insecure? Before COVID-19, the number was 27% among children, while 100% of children in public schools in Robeson County are enrolled in the free and reduced lunch program due to low income. All this has become more severe due to the economic standstill brought on by the global pandemic. If Karen had better knowledge of local resources, both Kyle and Karen would significantly benefit. Enter the accountable care community. So an accountable care community is essentially a coalition, a group of people, organizations that have agreed using a RASI chart or a memorandum of understanding and have collectively decided that they're going to engage in some sort of project. And in our case, we selected the parent-teacher organization of Robeson County, the Robeson County school superintendent, the farmers market in Robeson County, because there's only one, the North Carolina State University Extension, State Health and Human Services, and of course, Robeson County Health Department as the backbone. So our memorandum of understanding holds the Robeson County Health Department accountable, or ultimately accountable, for the success of all efforts to reduce childhood food insecurity in Robeson County. To do this, our accountable care community will increase access to healthy foods, particularly fruits and vegetables among children, to ultimately reduce childhood diet-related health challenges. As a positive consequence, our policy will reinvest money into locally sourced produce within Robeson County, ideally to increase reinvestment of those funds 10% above current fiscal year spending by the end of a 3-year initial pilot period. And as a quick aside, I did a quick calculation. If we invested $500,000 in food resource or food financing, we could expect a return of $708,000 or thereabout, and where that extra $200,000 is contributed to all the people who work in the food supply chain. And so, because that goes beyond the scope of this this talk, I'll provide some links and some information about that later. So with these objectives in mind, our root definition was created as a succinct statement of our vision, and I have it stated here. The specific program consists of Robeson County Innovative Nutrition Education Program, which is modeled after Durham County's own nutrition education curriculum. And this would be in conjunction with a SNAP incentive program called the Double Up Food Bucks program. The Double Up Food Bucks program has had considerable success all over the United States in both urban and rural settings. In addition, what is left out of the analyses is its economic multiplier effects, as I previously described. The technical details are beyond the scope, but considerations for implementation include SNAP authorization, point of sale and reimbursement procedures, bookkeeping and disbursement of tokens to participating fresh produce retailers. So taken together, although much of this project extended outside of my clinical expertise, I found the collaboration and creativity intellectually stimulating. So I have 4 takeaways. First, it's important to recognize that much of this type of work requires all stakeholders to move outside of their comfort zones into unfamiliar domains of knowledge. Second, whether your expertise is technical or non-technical, the most important factor is your willingness to make a difference, which sometimes requires the expert to become the learner. Third, community must be conceptually at the center of every decision. What this means for a given community will depend on what they perceive as the most important factors to be addressed. And lastly, some tools to help public health practitioners across the spectrum to innovate include co-design, journey mapping, and economic impact assessment tools like the Rural Health Information Hub, Economic Impact Assessment Tool, I'll provide the link, and the USDA and Colorado State University's Local Food Impact Calculator. Lastly, I want to thank the North Carolina Public Health Association for this opportunity to share my experience. And thank you to my colleagues and the UNC Gillings School of Public Health, and to everyone for your attention. If you have any questions, please feel free to contact me at askia.dunnan@gmail.com. And here are my references. And now I'd like to open up for questions. And I will provide some of those links that I had mentioned earlier as well.
Thank you.
Thank you, Amy. I will.
There is one question in the chat. Are you still working? Okay, great.
Sorry, I can't hear you, Elizabeth.
Oh.
Okay. I think I will stop sharing my presentation. Yeah, here we go. Yeah, I thank everyone for all the people who came. Thanks, Elizabeth, for organizing this.
Yeah, of course. Thank you for helping. All right, everyone else, we will see you at the next session with Ashton Johnson on minority diabetes prevention programs.
You know what? I'm not hearing you. I'm gonna see if I can change my audio. Could you say that again?
Yeah, can you hear me?
Yes, I can hear you now.
Okay, cool. I was just thanking you for presenting and taking the time to do this, and then telling whoever's left that next up is Ashton Johnson on minority diabetes prevention programs.
Awesome.
Cool.
Awesome. Yeah, I'm gonna jump into that session. All right,
Sounds
take
good.
care.
Bye.
Thanks. All right, bye.